As Badette was saying, our group's goal is to eliminate the number of needle sticks that a patient receives while eliminating waste resulting in both materials and time. The current process consists of a doctor ordering a stat CT exam with contrast from a clinic. The patient then comes to check into registration at the hospital. Should the patient require lab work to check for proper renal function prior to the CT scan, the patient is then directed to lab. The patient will then check into the lab and wait for lab personnel to have their blood drawn. This will be the patient's first poke. The patient then goes to the radiology waiting area where they wait for their blood test results and for the CT imaging personnel to be ready. As you can see on the map of Prosser Memorial Health, the black line represents the patient coming into the hospital and checking into registration. The patient then goes from registration to lab if they require testing to be done prior. The blue line represents the patient completing their lab work and going to diagnostic imaging, where they wait for the lab values to be resulted and for the CT tech to review them. Should the lab values be in an acceptable range, they go back to the scanner. Once the scan is complete, the red line represents the patient exiting the hospital. This map signifies the amount of time a patient wastes going from department to department and the time wasted in each. This also represents the initial needle stick at lab as well as in CT for the actual exam. Unfortunately, the amount of time waiting for such lab values cannot be eliminated, as these lab values are pertinent and important to know before contrast administration. A fair question to ask is, what are normal and abnormal lab values concerning CT studies? We use 3 values to test a patient's kidney function: BUN, creatinine, and eGFR. A normal BUN is between 8 and 25. A normal creatinine for a female is between 0.5 and 1.0, and for males, it is 0.7 and 1.3, with an eGFR greater than 60. Should the lab value fall in this range, the scan proceeds with an IV start, or, for the patient's sake, a second poke, and the exam being complete. Should the eGFR be between 45 and 55, the patient will need to stay after contrast has been administered for a 500 milliliter bolus of normal saline. This does not mean a third IV start, as we can use the same IV the patient already had from the scan. If the eGFR is less than 45, a radiologist will be consulted, and direction will be given from there. This could mean the patient may end up requiring pre- and post-hydration, which includes receiving normal saline before and after the scan, or perhaps the contrast dose is lowered, or the exam is proceeded without using any contrast at all. Either way, the radiologist will give that direction. Sherilyn will now demonstrate how we will utilize the PDCA process and brainstorm ideas for less needle sticks to the patient and how we plan to eliminate such waste occurred in this process.